The information shared on CNS Unfiltered is for educational purposes only and is not intended to diagnose, treat, cure, or prevent any disease. Always consult your healthcare provider before making any health or lifestyle changes. The views shared are those of guests and do not necessarily reflect those of Innate Clinical Nutrition or its affiliates. This episode includes affiliate links, which help support the show. Hello and welcome. I am Jenna Salisbury, and this is CNS Unfiltered, a show where clinical nutrition specialists uncover what traditional medicine overlooks. For all my listeners out there who've tuned in every week, first off, thank you. But you know that I've got into this work because I'm fascinated with the why of things. In the world of clinical nutrition and functional medicine, that's the most important question for us. Why is something happening in the body? Digging deep, doing the detective work, and finding the why is how we are able to help clients truly resolve the symptoms they're coming in with. There's always a why. In my practice, I've successfully helped hundreds of clients with just about every health condition you can think of, from IBS to SIBO to Crohn's to Lyme's to anxiety and depression, PCOS, perimenopause, thyroid disorders, and 1,000 other concerns. But there have also been clients who needed more than I can offer them in order to find relief from what they were experiencing. Clients whose symptoms have persisted even after I've worked to balance their gut and their blood sugar and their hormones and digestion. Stool tests are coming clean. Blood work is coming beautifully. They feel even great. There hasn't been many, but they do come through my doors. It's happened before. They had a missing link, a why I couldn't find. In this world of functional medicine, networking is key, right? Getting to go with like-minded practitioners to learn and deepen is a major highlight of what I love. One of my go-tos is called the Functional Forum. And for any to-be CNS practitioners looking to network, don't skip these. At this particular functional forum, I met Anna. Anna is there to present on the deeper impacts of pelvic floor work. And listeners, when I tell you I stopped in my tracks, I am not kidding. It felt like Anna was speaking to me, not a room full of professionals, to me. Anna's presentation highlighted how many health concerns can stem from pelvic floor problems, constipation, persistent hip or back pain, prolapses, incontinence. In that moment, I thought about some of those clients whose whys I couldn't fully resolve. And it felt like all the light bulbs were going off at once. For some clients, this could have been the missing link, the last piece of the puzzle, the ultimate why. I had a million questions. I knew I needed to talk to her more, and I knew I needed to share her with all of you. Have you ever thought about your pelvic floor? If you're not pregnant or postpartum, your answer might be no, but it might be beneficial. The scope of pelvic floor work is so much bigger than just reproductive health, and it's far more than just doing Kegels. Today, I'm talking to Anna Ballard, a certified pelvic floor specialist and physical therapist. We talk about pelvic floor PT as a specialization, how pelvic floor health is closely connected to mental health, stress management, and trauma, how pelvic floor work integrates with functional medicine and gut health, and so much more. I'm so excited for today's episode, and I know you will be too. Stay tuned. Hello, everybody, and welcome to CNS Unfiltered. We have Anna Ballard with us today, and I am so excited to have her here, especially for all of my women clients, and you will find out soon why. When I had met Anna at a functional forum, my gosh, the light bulbs were going off, and I had a full, deeper understanding of a tool that I was able to give my clients to really come to a complete healing in that physical sense when supplements work and the doctors run out of options or the only option left is maybe even surgery. I learned that Anna and other physical therapists could really kind of swoop in and help that progress without the surgery and possibly some medications. So Anna has come to us as a PT for women's health. She is a pelvic floor specialist, and she is also certified in LSVT. Welcome, Anna. So happy to have you. Good morning.
Good morning, Jena. Happy to be here.
So I'm going to turn it over to you so you can let our audience know exactly who you are, how you got here, and what exactly is pelvic floor PT.
Yeah, of course. I have been practicing clinician treating patients for 13 years now. I started out as an assistant and then I went back to school and got my graduate degree as PT. I have been treating pelvic floor for almost 5 years. It's a separate specialty, years of coursework that you take after you graduate. And once you you treat over 2,000 hours of direct patient care with pelvic floor, then you can sit for various board certifications in that specialty.
Did you just say 2,000 hours?
Yeah,
Wow.
so there are two main governing bodies that do all of the pelvic floor coursework, and they each have kind of their own like niche areas. And to get through their courses, the whole system, and then there's lymphedema versus men's health and all the little places you can take it to. It takes a year and a half to 2 years to get through all of their coursework. And then, yeah, 2,000 hours of patient care to sit for your board exam.
Wow. Whole new respect. Like you just keep getting layers and layers of wows from me every time I talk to you. That's a lot of hours. That's a
It
lot of
just speaks
experience.
to, yes, and it's lifelong learning. That we're learning new things constantly. And when you're seeing a clinician that is truly going through the training for pelvic floor, they're taking courses, one or two, every single year. They're researching things on the internet constantly, trying to find the best evidence-based care for their patients. There are not a lot of us, so they take it very seriously and they're kind of trying to drive that specialty forward. But yeah, it's a lot of work.
Well, thank you so, so much for doing the work.
Yeah.
And I sense and I feel your passion, right? Even from seeing your presentation at the functional forum, you can just tell like, you know your shit. And like I mentioned when you first came on, like I'm gonna be setting up an appointment. I got more questions, and um, I think you would be the missing link of filling in some of those gaps that myself and I think a lot of other women are just like, well, how do I get past this piece? Or I don't understand this one piece of my health. Awesome. So
Yeah, some people think it's just pregnancy or postpartum. Um, but I kind of joke at work that it's nipples to knees. Anything going on in that zone is kind of our bag. We get to dive a little bit deeper than your traditional orthopedic therapists might in those areas. So sometimes it's a supplement to my general orthopedic friends. It's a hip pain issue that doesn't seem to be healing up correctly. And sometimes it's IBS or chronic lower abdomen pain that isn't getting better with traditional treatment. People kind of find their way into pelvic floor PT in a lot of different ways.
And it's wild. Like that was one of the biggest aha moments that I had personally when I was hearing you speak was not just, okay, yeah, the pregnancy, we think pelvis, we think pregnancy or what, just that reproductive space for women. And so most of my women are, they're coming for bioidentical hormones and thyroid. So they're transitioning out of that space. But now what comes in is the constipation or the prolapses or the lower back pain or the lower stomach pain. And, of course, like I have a gut first practice and there are those select few that at the end were like, well, everything got better. Energy's better and skin's better and hair's better and stools are better. But like, where is this last piece coming from? Like where they're saying constipation and now I'm realizing, oh, this is prolapse. Or hey, they're saying lower abdominal pain
Sure.
or lower back pain and like, okay, this is alignment that's going to fix this constipation. It really again, that whole cohesive group of us all working together, all the practitioners, working together, that it is not just internal but very physical when it comes to these expressions also. Is there I mean, you kind of work through the whole gamut, I suppose, from nipples to knees. Um, what do you find that you see the most? Is it for like GI issues and constipation, or do you find it's more so for reproductive or pain?
I think it comes in waves. I think, sometimes when you start getting one prolapsed patient, you feel like you have 10 prolapsed patients, or, you build a relationship with one referring physician that saw somebody in primary care for constipation and it was successful. And so then all of a sudden they're sending all of theirs to you. So, um, I'm trying to think like even currently I have a really varied patient load as far as I have several abdominal pain, constipation, IBS patients. I have several like postmenopausal 60s, 70s prolapse slash incontinence based patients. I treat a fair amount of pregnancy, um, hip sacrum pain. I kind of see it all from a true pelvic floor perspective. Um, Pelvic pain, like pain with penetration, and bowel issues are my personal favorite to treat. I think that I just have a good language to get in with those patients. Um, and when just bowel, for example, like when that works, your day is so much better.
So much better. I
So
agree.
I love treating people with shoulders who need to get a jacket on and off or need to reach up for things like that's wonderful. That's so um helpful to their day and brings independence and I love that. But ah, you don't have to wake up at 4 in the morning to start your routine to have a bowel movement that day. That's super freeing.
So yes, because like that's like the end goal, right? So that's where I'm like, what is this last piece?
Hmm.
Because I don't even feel completed yet unless it's all flowing and not hurting, right? And what do you find? Okay, because I don't know nothing, so I'm gonna keep it over to you for a second. Like, how does it work?
So there's a study and I can't find it. So I can't quote the authors or anything. So apologies to
Okay.
them. But there's um generally speaking, I'll back up for just a second. Pelvic floor physical therapy research is not high quality research in the educational world because we cannot blind our treatments to the practitioner or the person. We don't like to randomize the treatment that people are going to get. People aren't going to, it's not a guess of, are you getting internal manual therapy or are you not? Like, there's
Right?
consent, there's explanation. We have a lot of barriers that we have to get through there. So most of our research is a lot of case studies or just very basic um, research studies for people. So we take a lot of our treatment approach from the mental health world because they can use cognitive behavior training or different types of mental health approaches, motivational interviewing, and different things with people to assess what's helpful. And so there is a study from the mental health world that they took surface muscle electrodes and they put them on big muscle groups on people's bodies, including at the external pelvic floor. And they showed the people images on a screen.
Say it again.
Am I muted?
No, you're good now.
Okay. Um, they showed people images on a screen, and the people had to say, like, did that make them feel positive or negative, the image? Before people could even hit negative, the very first muscle group that clenches and tightens up or activates is your pelvic floor. So when we're talking
Interesting.
about the bowel, for example, and somebody's had stress related to emptying or is like, gosh, I wonder if this is going to work today, or I hope this doesn't take too long and make me late, or I hope it's not painful, they're already clenching and tightening everything up at the pelvic floor. And when your pelvic floor contracts, it has synergistic muscle groups that work with it, which can be super helpful from a strengthening perspective, but can be bad from a somebody who's too tight perspective. So when your pelvic floor contracts, we can really quickly get glute contraction, adductor contraction, and ab contraction. And so then we can have this zone of tightness and clenching and pain, and it just, the cycle continues for those people. So pelvic floor has to come in as a physical therapy profession and first identify some of those cognitive triggers and how are we going to physically respond to that subconscious trigger. What's a breathing technique we can do? What's a stretch we can do before we have a bowel movement? What's a happy mental imagery situation that we can go to? Every person responds to something a little bit differently, but we have a lot of ways to kind of get in to what that patient might need to even start having positive thoughts related to going to the bathroom.
It is wild that it appears to be like instinctual. Like we hold and I'm only able to speak for myself. So women, how we hold everything in our hips and in that sacral space. I was just thinking back when you were saying that, it's like I remember just started driving and I remember going to college and I'd have a 3-hour drive back from Western to Detroit. And I was always so tight in my hips. I'd get out and be like, why am I so achy and so tired or not tired, but like achy and in pain, really, like getting out of the car, my tailbone twists and the whole 9 yards. And I remember having a conscious understanding once in the car, it's like, oh, like as soon as I sit in the car, like I am tight. Mind you, my mom, now that I'm saying this out loud, my mom was in a really bad car accident when I was in 6th grade. and I was in like two or three of them. So it might just be of that, hey, I'm in a car and this is dangerous. And so you hold tight.
Sure.
And I, even to this day, and I'm 38, about to be 38, that um, if I'm stressed, I have to mentally say, okay, I'm going to be relaxing my hips. But I never thought about my pelvic floor. It was all about my hips because I was worried about my tailbone because I can't sit. If my tailbone hurts, and that's what I do all day is sit and
Sure.
consult. Yeah.
Yeah, it's your fight or flight system, and that's a really big thing. Um, physical therapy, pelvic floor physical therapy. We have such a great opportunity to spend a lot of time with our patients and talk about situations like you're just talking about where people are like, "Wait, maybe I didn't even realize this situation that occurred 15 years ago could be like re-triggering how my body still responds." It's your fight or flight system. Your brain at its core is a survival mechanism. Its job is to try and keep you alive and safe. And unfortunately, sometimes it doesn't realize that it could be working against you long term a little bit, right?
Mhm.
So we have to retrain that. Kegels or like pelvic floor breathing exercises at the red light always kind of gets a bad rap, like, "Oh, don't just do it at a red light." But I think it's a great idea because how stressed and tight we are in the car when we're driving, we have that's a lot of machinery in our control and everyone else's control around us. It's a stressful situation. So at a red light, checking in at, wait a minute, what's my pelvic floor doing right now? And how can I take back control of how my body is firing and functioning?
It's,
A lot of times I'll talk to people about nerve pathways. So when your brain is really used to sending a signal, just think of something that's so easy that you do all the time, whether it's sports related, throwing a ball, or whether it's, muscle memory of how you brush your hair or brush your teeth or whatever. That nerve signal is like a 5-lane superhighway. It is paved, it is well lit, it is clear, it's so easy to signal. So sometimes that's bad, right? Sometimes we have 5-lane superhighways related to pain. As soon as a sense memory comes in, we get pain, we get weakness, we get triggers that way. So sometimes we have to break down roads and build new ones. And we have to respect that that takes a little bit of time and conscious training throughout the day, not just your once or twice a week PT session that you're going to.
yeah, because you're literally reprogramming the body's response emotionally, maybe even
Yeah.
spiritually and physically. And I love that put that all together because for those who really are into, like, how do we get to the end goal? How do we heal? They're all go together and it's all a
Hmm.
repracticing and a rewiring of how the body functions. I love that you put that part into your practice. How does the physical piece come in of like PT, right? Like it's really hard for me to kind of wrap my
Hmm.
mind around even visualizing all those muscles, how they go and thinking, okay, there's a exercise I can do because in my head, of course, like Kegels is it, right? Do all your Kegels and your pelvic floor is
Hmm.
going to be perfecto, right? And I learned that that's wrong. So can you explain a little bit? Because I'm sure Kegels Kegels are the number
It's not
one.
wrong.
Okay. All
I
right.
know they are. And so I always tell my patients when they come in, very first visit, you're going to expect a lot of chatter. You're going to give me your whole uninterrupted story. Anything you want, I don't know if this is relevant or whatever. Tell me everything, and we'll kind of put all your symptoms into the right box. And then the box that has the most stuff in it is the easiest one to kind of go after and fix for people most often. Um, And if we kind of get through some of those things, then we can address the other boxes. So the boxes that I talk to people about are weakness, tightness, or a coordination deficit. I don't treat a lot of weakness because, to your point, we've hammered Kegels to women in particular forever. And if that was the thing that somebody needed, it would probably work. I mean, there are exceptions to that functionally and doing a Kegel in the appropriate manner. And, I can argue with another physical therapist about that for days, I'm sure. But most often, if it's a weakness issue, people can address that on their own and they don't often come in. Tightness is a bigger issue that people are less aware that they have. They're less aware that they're clenching their abdomen or their pelvic floor all day and that could be negatively impacting how their bowel works or how they empty or contributing to their stress incontinence symptoms. And then coordination is kind of your catch-all. Like you can contract, you can relax, but your timing is a little off. When somebody throws a ball at your face, are you going to knock it out of the way in the right time? That neurological timing part is where the coordination can come in to play. So those are the two groups I treat the most of.
All
The
right.
very first thing we do is, do you even know where your pelvic floor is? And how do you talk to it, right? Like your pelvic floor sitting here, Jenna, you and I
Hmm.
talking, our pelvic floor has a rhythm to it when we breathe. And I think we're all very aware that when I breathe, my chest might rise and fall, my shoulders might move, my abdomen might move a little bit. Your pelvic floor is a part of that pistoning system. So when you inhale, it's slight. Your pelvic floor is a small group of muscles in the pelvis. So we're not looking for like huge arm reach based motions, right? But ever so slightly when you inhale, your pelvic floor will drop down. And then on your exhale, it will come back to its resting position. So I talk about it like an elevator sometimes. The elevator sits at the lobby, and when you inhale, it goes to the basement. And then as you exhale, it comes back up to the lobby. So before I can give someone a bunch of exercises to do, that's where I tend to start with my patients is, can you feel that happening, or do we need to get a towel for you to sit on to feel what your pelvic floor is doing? Or do we need to put you into a happy baby or a squat stretch position in order to kind of assess what's the best neurological in so that you can take control back of your muscle group, you know?
You want to know what's wild? So in my relaxation and learning this, and I felt it like you talked about, I'm like, okay, I relaxed another layer and then I feel it. But with my history, and knowing I have a prolapse, I was kind of afraid of that pressure down, thinking it was like something not okay, to be totally honest, until right now you're like,
Yeah.
you should need to feel that. I'm like, okay, but that was a little scary.
Yes, you're not wrong. You're not alone for sure. So people often misconception. People think if I'm going to have prolapsing, it's because everything is just so weak and it's falling out. And that could be true. There are times when that's what's happening. But often, too, your pelvic floor muscles start at your pubic bone in the front, and then they go into tailbone and sacrum, and then they wrap around to the other side. So that whole Kegel contraction is a squeeze and a lift up. So if that kind of U-shaped group of muscles is too tight, I'll sometimes compare it to like put a rubber band around your toothpaste container, it's gonna
Okay.
squeeze stuff out. And women have a very stretchy, pliable vaginal canal, which allows your pelvic organs, bladder, urethra, uterus, or rectum, to be able to be pushed into that vaginal canal tissue and make it seem like it's coming downward or, in worst case scenario, coming out. So tightness of the pelvic floor can be just as guilty of causing a prolapse as weakness. And so, to your point, we have to teach that person that it's okay to create some space for those pelvic floor organs to live, and then strengthen through that new gained range of motion.
Gotcha. Gotcha. Everything's in layers. All healing is in layers.
Yeah, yeah.
So, you've
So
mentioned
when
like,
people come in, oh, sorry.
no, please go. Yeah.
I was just going to say when people come in, they might come in to talk about a prolapse, or they might come in to talk about how they have just a little bit of leakage when they cough and sneeze. And I'll ask about every organ. I want to know about the bladder and their habits. I want to know about penetration, intercourse, health of the uterus and history there. And I want to know about their bowel and their rectum and their anus, because they're all neighbors and they're directly connected. And so sometimes people are like, well, why are you asking me? That's not what I'm here for. I don't want to talk to you about my IBS. So we have to kind of open that up for them and explain why they could how a rectocele, which is a prolapse of that anterior rectum wall into the vaginal canal, can put a lot of pressure on a bladder and create incontinence of the bladder. And so we have to fix the rectum and the bowel habits before the bladder will ever get better.
Got you. The method to the madness. And this is why you don't run a PT through ChatGPT. there's there's a lot more that goes in with it. So as you mentioned, tightness is one of the number one things that people come into. And what are some of those symptoms?
When I'm wondering if someone has tightness, I'm looking to hear about a lot of neurological input. So they might have urinary urgency. As soon as I feel like I have to pee, I have to go. And they might have a frequency also, which is that they just go more than every 2 hours throughout their day. Um, there could also at the bladder be an incomplete empty. Like I start to go, but I feel like my bladder is still holding on to something. I feel like I'm not getting everything out. That could be either because there's kind of the way the urethra comes down, if your pelvic floor is tight, there could be kind of a kink in the hose there. And so as things are coming out, they're not coming out in a straight shot. Or it could be because of that pelvic floor muscle tightness is a little bit of a vice grip on the bladder. And so there's a lot of neurological input. That bladder doesn't have the room to kind of expand and stretch as much as it should be able to. And so they feel every little sensation at that bladder. It creates a lot of urgency, frequency. It can mimic UTI symptoms. So burning, frequency, urgency, incomplete, empty are all normal symptoms of a urinary tract infection. But if that patient doesn't have a positive culture for a bacteria in there, then is the pelvic floor creating these issues is kind of the next question at the bladder. Pelvic floor tightness related to um, the uterus and vaginal canal most often will look like pain with penetration. And sometimes that can be positionally dependent. Certain angles, certain positions can cause more pain than others. So we get very close and aware of our patients quickly, which is perfectly fine with me. Um, and then at the bowel, it's very similar. Tightness can look like straining. It can look like incomplete defecation. Like I'm trying to get everything out, but it just feels like something is stuck in there. A lot of times patients will self splint, either push around in their glutes or their perineum externally to try and move things around to get stuff out, or they can go through the vaginal canal and push backwards to kind of create an easier opening. And tightness um, can also, people will say, my stool is really thin. It's really
Like a
thin and kind of
ribbon.
stringy. Yes, that can be directly related to those anal sphincters and the pelvic floor muscles not relaxing appropriately for emptying.
So someone who's been tight for, well, I don't know, we'll just say someone for 38 years. Like, how
Mhm.
long do you think that would take? Because, like, I know when I took in my daughter to PT and stuff, all of it that I think about is strengthening, right? Strengthening after surgery, strengthening her ankle, strengthening this. But yet, as we talk, we're like, oh, we got to breathe out. Like, we got to relax.
Mhm.
So, how does that work? Like, how does PT help you relax, and like how does that process, what does it look like?
So it's very person dependent, but generally speaking, I tell my patients to go through the full gamut. I like to see 10% improvement a week. So on average, 10 weeks of PT. Some people understand it. Oh, I get what I'm supposed to do. I understand lifestyle choices or behavioral strategies, and they're done in 6 visits. And then others that kind of um, maybe come in once a week for a while, and then every other week, and then every third, and stuff like that. It can kind of look however it wants based on someone's schedule. Neurological changes and retraining can occur instantly for people. It's just a matter of solidifying that pathway, like we talked about earlier,
Yeah.
um, recognizing what those triggers are and retraining that system. So those can take, a day to 2 or 3 weeks for people. The strengthening part and the coordination, that can take, you know, evidence shows 8 to 12 weeks for different people. So it's not a lifelong, you'll be in PT forever. Um, my bag, I try to, I always say I'm the most hypocritical PT there is, let alone pelvic floor PT. I don't have time for home exercises. I have a busy clinical practice. I manage our office. I have 2 small children. Like, I'm not doing an hour's worth of PT for my shoulder injury and an hour's worth of my home exercises for my hip and then my pelvic floor every day. Like, it's not a thing. So if I can give someone an exercise that they can do while they're brushing their teeth or while they're sitting at a red light, I can sign up for that for 2 minutes worth of that, or something while I'm putting my girls to bed. Happy to do that. Um, or I want to find what I call somebody else's position of confidence, meaning supine, laying on your back on a table is not always the easiest way for people to connect in to what their pelvic floor is doing. I don't know what this says about me, but postpartum with both of my girls, I'm back in the office, I'm practicing, I'm talking about the pelvic floor all day. So every time I'm asking my patients to breathe or step up or contract or whatever it is, I'm doing it too. Postpartum, I have the hardest time finding my pelvic floor when I'm sitting or standing. But if I go on hands and knees, I instantly know what to do. So I want to figure that out with my patients. What's your bias? Where are you going to get there fastest? That's our competence position. Let's challenge that. Let's work harder there. And then take a position that maybe is a little, our brain feels upside down. It's a little harder to connect to. And let's bring that down to an easier level, do the hard stuff first, and then go try. Do the position of confidence exercises first, the challenging things, and then pepper in a sitting or a laying down thing for you once a day. Like, but don't get stressed about it, because that's the other thing. It doesn't feel good to not know what your body is doing. And if you're just beating yourself up mentally every time you're doing your pelvic floor exercises, people are out, you know?
Yep.
They
Yep.
don't want to be a part of that.
A thousand
If
percent.
it hurts, that's the huge thing about PT in general. It hurts. What? It shouldn't hurt. Like, who wants to do their shoulder exercises if it's painful?
Yeah. Legit.
So if you're with a PT that's like, well, you just have to get through the pain, I would question that. Why? Is that how you do your home exercises? Are you in pain all day? I think we have a big no pain, no gain misnomer going on out there, a misconception, and it shouldn't be that hard.
Gotcha. Noted. Noted. Because I do hear that, right? Like I have clients that come to me from PT. I've just now started referring people to PT. Um, but yeah, it's that balance of stress, that stress state with that too, because then I'm working
Yeah.
with all those other pieces that come with why ever they're going to PT too, whether it's an accident or um an injury or whatever that is.
Sometimes too, it's, work smarter, not harder. So I have a patient right now that has a 30-year history of constipation, IBS diagnosis, doesn't know what's wrong. And she has really good mobility forward and backward in her spine and her hips and her pelvis. And so there's a part to bowel motility and slow transit constipation that we need to get your body and therefore your insides moving. And if everything in your day is forward and backward, and that's obviously not working for you, have we done any twisting recently? And does that have to be a huge, painful, make you feel vulnerable twist, or can you just lay on your back and move your legs side to side, or can you swing one leg and then the other? Um, the benefit of going in to see a PT is that I have millions of exercises that exist in my brain. It doesn't mean you need to do all of them. I need to find, what are you not already doing in your day-to-day life, and how can I pepper in just a little bit of variety in there and see if that's all that it really takes to kind of kickstart that motility for you.
I love that. And that really is the beauty of working with an expert that knows what type of questions to ask, what they're looking for, how to find the upstream and work through the whole cascade that's happening there. And we kind of touched a lot on the woman's part of things, and now you've brought in the IBS and Crohn's. Like those are really big diagnoses. I work with them every day also. And so I am so intrigued to hear your side of the world when it comes to those types of patients and clients, because obviously I can know what I do inside as a nutritionist or with testing and what I'm looking for and how to bring down the inflammation. But like I said in the beginning, sometimes my perception of the end, right? The client's gonna be feeling better, the inflammation's
Mhm.
down, the stool test is clean, but yet we're still having some of that constipation, or we're still having some of that loose stool, or we're still having some of these hiccups that it's not a food sensitivity. It's not, we've ruled out everything. So now I understand your role, but I know a lot of people don't come see a nutritionist until the very end of the line also. So I'm sure you're seeing a lot of people who haven't gone through, like all of the healing from that internal piece. So how does that go for you? I'm so curious.
Yeah, we get people who come in and they'll say, my GI doctor just told me to increase my fiber and it's not working.
Right?
And I'm like, well, how much fiber were you taking before? And how much are you doing now? And they're like, oh, I don't know. I've never tracked. I'm like, okay,
Yep.
well, I think we have to start there. That's not a baseline statement to anybody. Just up your fiber, right? What if they're getting all, I don't constipation? What if they're getting all soluble fiber and they're just
Hmm.
bulking everything up and their stool is so hard and it can't pass through,
Yeah.
So we're spending a lot of time with people trying to figure out yeah, what type of fiber are you taking? Because it's not all created equal, or how much water are you drinking? And when you go to the bathroom, what does that look like? The number of people that don't realize that you are supposed to breathe when you're having a bowel movement is a lot. Um, I have a lot of patients that come in just on Miralax and they'll say, well, my doctor said it's safe. It's not bad. It's not habit forming. It's okay to be on Miralax forever. And I'm not going home with anybody. So it's fine. It's up to you what you're comfortable with and what you want to do, but I wonder, is Miralax solving a problem that could be solved in a different way? Could you get off of that Miralax by drinking more water or adding more movement into your day? Or is there another way around that? I, I hear what physicians are saying when they say that Miralax isn't um, like a habit forming medication, but it's also not addressing the underlying issue of why that person needs to be on Miralax. You know what I mean?
Exactly. Exactly.
Hmm.
Because trust me, I get those clients all day too.
I'm sure you do.
So then
Yeah, so people are surprised. Do they think, oh, I'm coming to physical therapy. Do I need my tennis shoes? Am I going to get on the elliptical? And sometimes I'm like, no, we're going to learn all about fiber today. And we're going to talk about why you shouldn't be just in case going to the bathroom all day and stuff like that. It's a lot of education, as I'm sure you know.
I love that you put that in there because we're such a multifaceted system. There really is no way that we can't work together. We have to look at the inside and the outside. So, are there mechanical pieces that you are working on strengthening when it comes to like the colon? If someone does have like a prolapse, or if something is just not fitting right? I guess I don't know how to explain that, but things move in there.
Yeah.
Yeah.
So there's two parts to that. Um, the first part is when something's not moving, we need to create movement and create space. So a lot of times I have this technique called abdominal wall massage. And essentially, um, I have people think of their abdomen like a square, and they'll go from hip up to rib, over to the other rib, down to the hip, and then back to where they started. So in that square, they'll do these little circle massage movements, but I know this is a podcast, so people aren't going to see, but Jenna, if you can see, I'm just like
Hmm.
ever so slightly moving the top layer of the skin
Gotcha.
on my
Very
hand.
gentle, penetrating maybe
When
less than a half inch.
Yes, because all we're trying to do is bring blood flow to an area because that's helpful. It promotes motility and healing. And maybe stretch fascia layers. People could argue about how well we're really doing all of that. But when you really dig in at the abdomen, because your viscera is right there, your body will tighten up to protect that. So we don't want to push really hard. That's going to cause everything to shut down even more. So I'll tell people twice a day, and I do this when I'm putting my kids to bed, and I'll just, take 3 to 5 minutes and kind of massage into your abdomen. And first of all, that's another guarded area when we're stressed. So it helps to calm your central nervous system. It gets us that tactile feedback from ourselves, gives us a little bit more awareness of like, oh, I'm always tight on my left side, but I always feel fine on my right side. Then when I hear that as a practitioner, I'm like, oh, okay, this is descending into sigmoid colon stuff. Or if it's across the lower part of the abdomen where the uterus is there endometriosis? Is there scar tissue? Was there a C-section? Like, how does this all interplay together? So we kind of start with really gentle, get to know your body, get things moving in a nice way. We have no like real research understanding of why that works. So I call it my black magic trickery that I get to do with people. It's not very like evidence based, but it can really work for people. Introducing, again, like we kind of talked about earlier, some people's bowels move really well when they introduce forward backward movement. So doing like cobra, back bends, press ups, or doing like leg swing type movements can encourage mobility through the front of the trunk because we sit all day. And so I'm so tight in my front and I'm so stretched out through my back. We're just trying to like go in the opposite way. Or do some people need more rotation, twisting type movements? So we'll figure that out in talking with someone, whether they can tell me like, oh, I'm an accountant and I sit all day at the computer, then I kind of have an idea, or we'll do a movement screen and kind of look and see if somebody has some deficits in one direction or another. As we go through that, then we want to strengthen through that new mobility, but we want to strengthen functionally. So we've created all this mobility. We have space now for our abdominal pelvic organs to move the way they want to. If you're only ever doing a Kegel sitting or laying on a table, that's not really going to help when you're standing at the sink doing the dishes, or when you're walking up and down the stairs, or when you're squatting on the ground to pick up kids' clothes or toys, or, fill in the blank, right?
Hmm.
So we have to figure out what's going on in your day and how can I take what you're already doing and add your strengthening into that piece of it.
I love it. Personalized PT.
Mhm.
When, you've mentioned the fascia a few times, and you've also
Mhm.
referred to many yoga poses. Um, would you say that if someone maybe they don't have a primary care, they know they might not get a referral to PT, but they're listening to this being like, okay, like I have hope. There's something I can do to help fix this. Um, would you say that going and doing yoga once, twice, three times a week might just be a good starting point? Is it a good kind of catch all? Just curious that it's been brought up a few times.
I'm biased. I love yoga personally. I went through a teacher training many, many years ago in a previous life. So um, I think yoga fits for everybody the same way I think everybody would benefit from PT. Um, when someone comes in and they tell me, I'm already going to yoga twice a week, then I'm like, great. This is how I want you to think about your pelvic floor in downward facing dog versus when you're in a warrior position or whatever, right? So I just want to take things that somebody's already doing and use it to their advantage. It will also give me a little bit of an idea if someone says, well, I do yoga 3 times a week, or I do Pilates 3 times a week, or bar. Just gives me a sense of their movement style. And honestly, though, what's not working for them, right? They're already kind of doing those things, and they're still coming in with an issue. So I don't necessarily want to just hammer strengthening on that person because they're already there, but they still have a problem. So sometimes I want to back up and like really make sure that we're not missing something that maybe is incomplete in their exercise practice, or their exercise practice could be exacerbating. I mean,
Sure.
actually, I, again, like I said, really, really big into yoga a long time ago. So I have a 15-year-old hip injury from practicing kind of not in like the safest and most effective way, not always listening to my body and pushing a little bit. So as a PTA and a PT, I would treat myself, and I could always get it 90, 95% better, but there was always this like lingering left hip symptom that I could never fully explain. It always eluded me, and sometimes, you're too into your own system. It's hard to be your own clinician.
Mhm.
It wasn't until I went to my very first pelvic floor clinical education coursework, and we practice internal muscle assessments with each other when somebody was palpating and assessing all of my pelvic floor muscles, and they found my obturator internus, and that was the hip pain I had been chasing for 10
Mm.
years. And I was like, oh, light bulbs. That's what I've been trying to address. And as soon as we figured that out, I know what my exercises are. I know how to stay on top of it. It was game changing. I
Awesome.
have a patient right now that is a physician herself, and she has a 6-year history of pain, also on her left side, sacrum pain. And she had a trauma, and she went to multiple PTs, and we threw every trick that we ever could at her. And she saw a pelvic floor therapist, and I kind of rag on pelvic floor PTs a little bit as one, because I'm always like, they go internal too fast. Sometimes they don't look at the big picture, what's happening
Mhm.
at the thoracic spine. I call it the forest versus the tree. Pelvic floor PT is very like into the tree,
Yep.
one area, and I think we need to look at the whole person more.
Agree.
So in this situation, this physician went to a pelvic floor PT who didn't do an internal exam, which is unusual. And I would have supported at the time that person said, yeah, it doesn't make sense. It doesn't fit. I don't think this is it. So because of that, I have the benefit of timing, and all these other practitioners have looked at her for years. So I did an internal muscle assessment, and the same thing. I found her pain that she's been chasing, and injections and surgeries and dry needling and all these things for so many years. And we found her symptom, and in 5 visits, she's 80% better.
Wow.
So it's sometimes from the even the orthopedic world, that pelvis can kind of hide and hold on to things that people don't always know about.
Understood. Understood. I find that I'm in my world's gut health, so I find that all the time in gut health, right? Like everyone wants to
Yeah.
jump to the either recolonization or the killing. I'm like, well, y'all, like that's like
Yeah.
2 weeks out of the whole 6 months that we're gonna do. Maybe 3 to 4 weeks, but like it's the tiniest piece of what actually has to be done. It's the whole environment. It's upstream. It's digestion. It's
Mhm.
the
Mhm.
evacuation. Like you have to look at the whole forest if you're actually going to make it out of the forest alive. And it's
Right.
yeah, yeah, beautiful.
I propose it to patients as we have, every visit we have options and we can go bottom up or we can go top down. We'll get there eventually. We'll cross every T and dot every I. We'll address every little thing. But because, sometimes people come into pelvic floor PT and they're like, this is what I thought we were going to do. This is what I want. And therefore, let's make sure I'm prioritizing my patient's list,
Yep.
but keeping in mind that there are other things that we need to make sure we're not missing in the whole gamut of your body.
1,000%. 1,000%. I love how you practice. I resonate with it so well. I love it. I appreciate the way you practice and sharing your gift with everyone. Is there
Gold
like a
star.
word of advice you would give for anyone listening today about PT or their pelvic floor in general, or anything that you wish you can just kind of send out that everyone should know?
I think I would say two things, and you kind of mentioned this earlier, which is that in the state of Michigan, in physical therapy, depending on your insurance coverage, you technically don't need a physician's referral to initiate the process of PT. So if you have questions and you have somebody and you want to kind of figure out, you can call and set up an appointment, whether it's a consult or an evaluation, and get the ball rolling to see if PT is right for you. I never want to waste anyone's time. So if I'm working with a patient on the first visit or maybe we're 2 or 3 in and I'm like, "Oh, your gut health is a mess and this is never going to work. We need to get you to a clinical nutritionist and a functional med and all of these things." We want to be honest with our patients about that. So it's sometimes easier to get into PT than to wait for a primary care appointment and start that whole process. So it doesn't hurt to ask, and it's easier than ever to do. But the second thing, maybe more functional, is if people go back to that whole elevator. And there's a part to that elevator that I didn't mention. So when you're sitting at rest or you're laying down or you're standing up, it's the same. Your pelvic floor should drop to the basement when you inhale. And then when you're resting, exhale, it should come back up to the lobby. But the Kegel is a contract and squeeze up to floor 2, for example. So people can check in on their pelvic floor and practice that. Inhale down to the basement, exhale to the lobby, inhale to the basement, squeeze to floor 2, inhale all the way back down. That process, if someone came in to me and said, I already know that I can do it or that I have a really hard time getting to the basement or whatever, then I know exactly where to start. And so that's so helpful. And it's just good for people to be aware of how their pelvic floor moves.
So when my physician recommended I do PT, the insurance started sending me options to get those games, the insert thing that
Yes.
the game. So like after I saw your presentation, I'm like, oh, is this just teaching Kegels or is it teaching the like the push? I think it's the relax too because you have to let go. So you like that game or activity or exercise that's productive?
Yeah.
Cool.
We in, medical sales and devices, just wanting to get like, I don't even know, Q-tips related to pelvic floor, they're hundreds of dollars. That's an exaggeration, but you know what I mean. Like
Yeah.
as soon as it becomes a medical device, it's very expensive. So it's wonderful that these devices are on Amazon now. Um, there's two different modes to what you're talking about. So one where you're inserting a device into the vaginal canal, or you could have some will have like an external a sensor pad you can put on like around your anus or at your perineum. That is called, but there's no input. You're just watching a kite move up and down, and you're trying to make the kite go higher to move through a ring and then come back down and watch out for the bird or whatever.
Hmm.
There's all the different types of iterations of that game. That's called biofeedback. So that's just sensory input measuring whether your pelvic floor is contracting and relaxing to the level that we want to get it to. And it's great. There's great evidence for biofeedback for people. Some people have a hard time doing that on their own. They need more external validation that they're going in the right way, or they can contract really well but they can't then relax. They get all kind of bundled up. So there are downsides to only, if it doesn't work, there's an option for people, right? Or some of the vaginal trainers have like a electrical input, a pulsation that is going to forcibly contract the pelvic floor and then relax. And there are different timing cycles that all of these machines have. The home versions are lower level than what we can do in the clinic, so they're considered very safe. Generally speaking, for a person with weakness, that electrical stimulation product is good. Again, when my patients want to use that on their own at home, I'm very specific with them that they are helping with the contraction and not just making the muscles do it making the machine do it on its own. You know, you can't just be sitting watching a movie for 2 hours and having this machine contract your muscles for you and then expect to not leak every time you cough, right? Like that won't work for people. Otherwise, that's how we would all be the strongest people in the world. We would all be putting electrodes on our muscles and just having it pump us all day, right?
Hmm.
So if there is a way to take that electrical stim machine and make sure the patient is also participating in the contraction and doing it functionally, sit to stand, squat, deadlift, going up and down the stairs, whatever their thing is, when they're leaking, they need to pair that activity with that strengthening exercise in order to get rid of whatever their symptom is, right? It's
Gotcha.
like, I'm having trouble with my shoulder reaching into the top shelf of my closet. And when I'm at PT, I'm only ever doing exercises at the chest level. That's never going to get your goal that you're
Right.
after. So sometimes it's just a conversation about how do you take what you're already doing and maximize it for whatever your goal is.
Awesome. Do you happen to have a myth that you would want to share?
Jenna,
Yeah,
I wasn't, a
I know.
myth.
A myth.
Oh, so many are popping into my brain. Okay.
You can do more
How
than one.
controversial do I want to get, Jenna?
Unfiltered, girl. We can go as far as we want. Let it out. I'm so
Okay,
curious now.
my, I know, right? My most I think my most controversial myth could be that I don't fully believe in bladder irritants. People come in
Ooh.
with incontinence and leakage, and they're like, well, I cut out coffee and I cut out pop and I don't put any citrus in I don't have salsa or pizza sauce anymore. And they have no joy.
Oh.
And so sometimes interstitial cystitis is a real thing for some people. Sometimes bladder irritants is a real thing. And there are some people who swear by a certain acidity level in their coffee can create more urgency or incontinence. But largely in my practice, we can get people to train their pelvic floor appropriately and they can eat and drink, within reason, whatever they want, right? Like we don't want people putting garbage in their body all day, but we also shouldn't freak out just because somebody had a coffee.
Right.
It should be, your body is so strong, it should be able to handle it. So I think that's my controversial myth.
Awesome. Awesome. And of course, the nutritionist sitting across you, I was like, ooh, we talk about that. So, because I'm looking all through like the toxic load, right? Gut first, I see a lot of
Yeah.
bacteria and a lot of those being more irritants. I agree with you actually. Like, food really isn't the thing. I'm not looking at food because I agree 1,000%. Our body's designed to handle all the foods. So, if someone tells me food's the issue, I say, no, it's not. Unless you're like really
Yeah.
allergic, right? Like, okay, then yes, food could be the issue.
Sure.
Um, but it's all about the way I look at it is the toxic load, right? And there can be many things to that toxic load. The body doesn't know the difference between mental, physical, spiritual, emotional pieces of that toxic load. And I think it actually plays in, you know, if we hold all of our tension and all of our stress within that womb space, um, then the toxic load is already high. So then you put something that might irritate
Hmm.
the bacteria, or maybe we don't have bacteria in there right now, or we don't have enough water. So there are extra toxins going on inside of there that um, we're gonna have the side effects.
Jenna, you just hit on another one. People come in and say to me all the time, well, I'm not drinking water because I could leak. And so
Yep.
having to explain to somebody that a dehydrated bladder is mad, irritated, and it is going to contract to get any little thing, that ultra concentrated urine has to come out somehow. So actually drinking a little water can keep you a bit more continent is kind of a head warp for some people, you know?
Definitely. 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 And also too, like another one that I had learned is like when you're too tight, it actually causes leakage. Is that true? Yeah.
Yeah. Yeah.
So, yeah.
Yeah. That goes back to it just squeezes on that bladder.
Yeah. So then you're going to have the leakage where we think, okay, well, now I'm weak because I'm leaking. But in truth, and again, this is where we don't use Dr. Google to decide which is which, right? We go see a professional who could talk it out and use their massive brain in this area to say, okay, for you, this is what's going on, and for you, this is what's going on. Wow,
Hmm.
thank you so much. So when you say you can get those continence, do you find that it's like a pressure thing inside? Do you feel like it is a physical thing, or do you feel it's more so along the lines of like the mental and the things that they're putting into their body?
Wait, ask me that again.
Yeah, 1,000%. So for your myth that it's not food irritants,
Hmm.
that you can
Mm.
usually get that corrected using PT. So it makes me wonder, like, is it like a physical thing where like we physically have to like be moving it out and like we have a structural thing that has to be addressed? Or do you find it's mostly more like food and mindset, like, like the stress and the sleep and the food that actually opens up?
Um, Both. This is
Yeah.
general, but a lot of times it's behavior. So there again, I can't quote this study. I can't because I learned this a long time ago, 8 years ago. So it's kind of
Okay.
probably outdated. But and it was in England, I think. Um they took a bunch of people through therapy, pelvic floor therapy, and half of the group did education only. What is the pelvic floor? Where is your bladder? How does your bladder work? How much should it fill? Explained all of that stuff. And they did that over 6 or 8 weeks. The other group did all of that and they did manual hands on pelvic floor therapy with exercise. At an 8 week follow up, the group that did education only remained 60% improved. And the group that did PT, traditional PT plus education, remained 80% improved. So, what we really need to take away from studies like that is that education, learning how your body works, is 60% of the battle. It's not about you coming in and I massage you and I give you exercises to do and I do all the work. And so, the reason why I bring that up is because I have so many patients that come in and are driven by what their brain is telling them to do. So our brain, unfortunately, can be easily tricked. Our brain is no longer listening to the signaling from the bladder of the bladder saying, oh, hey, I'm half full, heads up, or I'm 75% full and maybe we should get around to emptying. I have patients that my favorite patient was a ICU nurse. And her thing was, I'm so afraid that I'm going to be in an emergency or somebody's going to be coding or whatever, and I'm going to have to pee or I'm going to leak. So to avoid that, every time I see a bathroom sign, I go to the bathroom. So she hadn't even realized that in a shift, she's going 15 or 20 times just in case. And so now her brain is driving the bus in a way that is inappropriate and it's creating a muscular pelvic floor dysfunction. So when people talk about food or dietary irritants, it's like, well, is it, or did your brain just tell you I had a cup of coffee and so I better get to the bathroom? We're Who's taking control of the decision making, our conscious or our subconscious? And so sometimes it's that behavior conversation where people will fill out a bladder log. And it's like, well, why are you going to the bathroom every 45 minutes between 7 and 10? And then all of a sudden you can hold it for 3 hours. What's the patterning going on here? Sometimes we have to kind of look at that written down before we realize, oh, I can hold it. Maybe I should try that after my cup of coffee, you know?
Yeah. I'm so glad we didn't end before you brought all that home because it is so true. Like, and I repeat that to my clients too. Like, we got to throw a gear in. It's between the head and the body, and they're a cycle, and we
Mhm.
got to decide which one's driving, and that's where we get to throw the gear in first. And
Yeah.
so that's exactly I'm following, and that's such a great take home. That's so powerful. Something we can do as part of that retraining that we
Mhm.
started off talking about.
Mhm.
Anna, it has been amazing speaking with you today. And I know probably every woman that is listening to this podcast right now is gonna be like, oh, wow. Okay. If they're like me at all, they're going to be like, light bulbs. And I probably need to go see a pelvic floor PT now. So, where can they find you, or how could they find, since you mentioned there's not many of you around, how would they go about connecting, especially if they don't have a doctor referral to find you?
Yeah, two ways. So for me specifically, I'm at the Center for Physical Rehabilitation in Cascade. And our company has a lot of offices. 5 of them currently house pelvic floor therapists. So we're in the Grand Rapids and surrounding area. Our website is pt-cpr.com. And I'm Anna Ballard, so they can look me up that way. But globally, if they're somewhere else or I'm not everybody's bag, which is perfectly fine. There's one of our governing bodies is called Herman and Wallace. They have a website, hermanandwallace.com, and they have a find a practitioner tab on their website. So people who go through training with them, you can put in your zip code or you can put in your city and your state, and everyone who's registered through them will kind of pop up with these little pins that you can. People have varying levels of bios and pictures and different things on that Find a Practitioner website too.
Perfect. Perfect. Thank you so much again, Anna. This has been so wonderful and so educational. And I am really excited to partner and have even another tool in my toolbox for my clients. Thank you so much, Anna, for sharing your incredible depth of knowledge with us and for doing such important and valuable work and for letting your passion shine. Thanks to our listeners for tuning in today for this episode of CNS Unfiltered. Integrative medicine is powerful, y'all. Approaching your health holistically and finding a team of people who understand and value that is how you can completely transform your health in ways you never knew possible. Take care of your pelvic floor this week. Give it some thoughts. Consider it all that it holds for you. If you're interested in working with Anna, go to pt-cpr.com for more information. She is located in the Cascade area of Grand Rapids. If you're not local and you're still looking for PT, go to hermanwallace.com and search for a certified practitioner near you. If you're interested in working with me, check out innateclinicalnutrition.com to schedule a free phone call. If you're a future or current CNS or future medicine practitioner, medical professional, or functional medicine patient, we want to hear from you. If you have questions, comments, or success stories, send us an email at cnsunfiltered@gmail.com for a chance to be featured on a future episode. If you're a clinical nutritionist or other functional medicine practitioner and you're interested in being interviewed, click the link in the show notes. Be sure to subscribe wherever you listen and follow at Innate Clinical Nutrition so you don't miss a new episode. And share this with a client or classmate who might need to hear it. Once again, I'm Jenna Salisbury, and remember to listen to your gut.